So welcome. Thank you to everyone for being here. My name is Andy Tucker. I'm from the Global Partnership for Zero Leprosy, and I'm very pleased to welcome you to this webinar, which is the second in our series of SDR-PEP webinars hosted jointly with WHO's Global Leprosy Programme. Today, we will be exploring the key role organizations of persons affected play in making SDR-PEP implementation successful. We'll hear first from Dr. Erwin Cooreman from WHO's Global Leprosy Programme, who will introduce us to SDR-PEP, explain what it is and why it's a powerful tool in the fight to end leprosy. We'll hear from a community member in Papua New Guinea sharing his perspectives on SDR-PEP via video. Then we'll hear from Dr. Alice Cruz, UN Special Rapporteur on the elimination of discrimination against persons affected by leprosy and their family members, who will share with us key issues for consideration for those working on SDR-PEP implementation with organizations of persons affected. Mr. Amar Timulsina from IDEA Nepal and Mr. Nand Lal Banstola from NLR Nepal will share examples of the ways organizations of persons affected and SDR-PEP implementers have collaborated in their country. And finally, we'll hear from Mr. Tesfaye from ENAPAL, who will share his perspectives on SDR-PEP. Our webinar will conclude with a time at the end to pose questions to these presenters, so feel free to submit questions during the webinar using the Q&A box, and they'll be responded to at the conclusion of the presentations. So again, thank you all for joining us today for this conversation. And to start us off, I'll pass the microphone to Dr. Erwin Cooreman from WHO's Global Leprosy Programme to introduce SDR-PEP.
Thank you, Andy, and good afternoon or good evening or good morning for wherever you may be. So I have actually two presentations. So one before the video of Papua New Guinea on the essence of what is PEP, why it is needed, what is the benefit of it, and then after the video more on how we can implement it. For those who have also attended the global consultation of program managers, partners, and affected people a few weeks ago, or in the last week of October, you may have heard already what I'm going to say. I have a bit of fine-tuned it further, but for those who have not heard it, okay, I hope it will still be useful. So shall I share my screen or will you do it at your end, Andy? Yeah. Okay, go to the second slide. Yeah, so the first part I will explain the WHO guidelines, and these guidelines say specifically what should be done. It's more as a policy document. Next slide. So before that, let's look for the effect of leprosy on contacts. So the blue bar shows in a particular study, the incidence rate of leprosy in the general population. And as you can see, it's below 16. I think the numbers are not very important here. It's more that you see the difference between the general population and then different types of contacts. And then we have identified three groups of contacts. One are the social contacts, neighbors, and household contacts. All three of them have a significantly much higher attack rate, if you wish, or incidence rate of leprosy compared to general population. But among the contacts, if we split them into three groups, we see that household contacts are most likely to be to having secondary cases, less in neighbors and even less in social contacts, but still more than the general population. Therefore, it's worthwhile if we do active case detection with the purpose of finding cases also earlier, that we focus on these contacts, because this is what we consider as the low-hanging fruit for active case detection, because it's more likely that we will pick up additional leprosy cases there compared to doing total population surveys, which have very low yields. Next slide, please. So this is under WHO guidelines. You may have seen this document. It was published in 2018, and it has three components. One is on diagnosis, one is on treatment, and today we will focus on the third component on prevention of leprosy. Next slide. So the guideline or the recommendation is answer the question, is there an effective and safe chemoprophylaxis, which means medicine, a drug, for the prevention of leprosy? What is the population that we studied? We studied the contacts of both PB and MB index cases, both adults as well as children, and also population of endemic areas. What is the intervention? Intervention was single-dose rifampicin provided post-exposure to these contacts, and we compared it with not giving SDR. So it was SDR versus no SDR. What happened in both arms is that we did the periodic follow-up to find out if there were cases. And what is the outcome measured? It was what was the disease? Was there more or less or equal amount of disease in the group that received SDR compared to the group that did not receive SDR? So let's look to the result in the next slide. It's a bit complex maybe, but this is the main result of the study. So it was a randomized control trial, which means that two groups, that contacts are divided into two groups. One group receives single-dose rifampicin, one group received placebo, which means another tablet which looks similar, but it's not rifampicin, it's just nothing. It doesn't contain any active ingredient. It's double-blind, which means that we don't know beforehand who received what. That is to avoid any bias in our follow-up of when we do check populations. So we give them one tablet. The tablets look the same, but we don't know whether it was the SDR or whether it was just some starch or or a placebo. And then periodically after every 6 months or so, or every year, we checked in these all these contacts how many patients came up, and then plotted this in the graph. Let's go to the next slide. So this upper line shows you the decline of patients in contacts who did not receive SDR, and that may be a bit surprising. Why should it go down? Because we are not giving anything. It's just that is because of the periodic examination that we did identify the cases among these contacts, and obviously the cases were treated with a full course of MDT, and that also reduced the transmission among these contacts in spite of not having received SDR. So the colored area, the size of it is a measure for the number of patients that were detected in this group to bring it down to the level of community transmission. So around about the level of about 15, 16, the horizontal line is the same level as leprosy occurring in the community. And what we see is that to bring it down, it took about 4 years to bring down the number of patients in the contacts who did not receive SDR, who received a placebo, to bring it down to the same level as community transmission. Next slide. This shows us what happened in the group that received single-dose rifampicin. Also, the number of patients that were detected, it's not zero, unfortunately. We still detected a number of patients. But what we see is that the area, the colored area, is much smaller than the previous slide. So first of all, there were much less patients in that group, and the two groups are equal size. The number of contacts, each group had about 10,000 contacts. So the number of patients detected in that group was much smaller. And also it is much faster that we reach the level of community transmission. So that is actually the benefit of SDR. That was the effect of SDR, because all other things were equal between the two groups, except that this group received single-dose rifampicin. So single-dose rifampicin could bring down the incidence faster, and there were much less patients detected in the group. Next slide. So this is actually the difference. The yellow colored area shows actually the number of patients that were prevented, that did not develop leprosy, because these contacts have received SDR. Should we not have given SDR, then all the patients in the yellow area would also have developed leprosy. And in terms of what does it mean in absolute numbers, it's about we have to treat about 333 contacts to prevent one case among contacts. And that means it's a reduction of about 57% after 2 years. So it's a misconception that SDR protects only for 2 years. SDR, rifampicin, is not a vaccine. It protects only for 1 day. You take it, you kill all the bacilli in your body. If you do get infected next week again with a new infection, you are no longer protected. So that can happen, of course, in a high endemic area. So it's not a vaccine, but it is only that it takes away a pool of infected people already. Plus, because we have to we check also the people if they have cases, and if there are cases, then they are treated with the full course of leprosy. Next slide. So based on that, we came with the recommendation that single-dose rifampicin can be used as leprosy preventive treatment for contacts of leprosy patients in adults and children above 2 years. Why above 2 years? That's a more of a safety precautionary measure. We didn't have any analysis of younger children. Of course, we need to exclude active leprosy and also active tuberculosis disease. And there are some other contraindications. The reason is because if you do have leprosy, then single dose, then you need a full course of treatment with MDT. Or if you have tuberculosis, you need a full course treatment for TB. A single dose rifampicin is not going to cure you, and monotherapy is actually not advised for treating active diseases. So therefore, we need to exclude both leprosy and TB. It's an intervention that builds on adequate management of contact. So programs that have already contact tracing in place as part of, because contact tracing is nothing new. It has been a policy, it has been a recommendation for many years, probably as long as leprosy existed. If that is already in place, then it's a little add-on to give single-dose rifampicin to it. Will be a little bit extra effort, but with immense better, more benefits at community level. And we also need the consent of the index case, and I will talk later about consent taking and so about that. That is to respect the human rights of the persons affected, because we know leprosy is a highly stigmatized disease in many countries, in many settings, and therefore we must be careful before we label or before we disclose the disease status of a person to the wider community, particularly outside the family. Next slide. So this shows you in the details on the dosages of rifampicin, one time given. So what I have explained you till now was the efficacy. That means what is the impact of SDR in the ideal situation in the research setting. Is it feasible? Which means that if we do this on a routine basis in a normal program where we have all the regular difficulties that come along with routine program implementation, the results may be slightly different, but feasibility study has been undertaken in several countries under the LPEP program, sponsored by the Novartis Foundation, has been published in the meantime, and it has indicated that indeed giving contact tracing followed by SDR is perfectly feasible in most settings, and it has even much more beneficiary effects, including rejuvenating the entire program. We also have another option is blanket approach. Blanket approach means that we do not identify contacts of an individual patient, but more in highly or hyper-endemic areas where leprosy is very common, where there is a very high transmission, that it's better maybe to consider treating the entire population of a limited area, assuming that there is a high overlap of contacts, rather than going for individual contact identification. In such case, it is not required to obtain the consent of the individual case. We just need to inform the community that leprosy is around in the community, and therefore we want to offer this additional tool of rifampicin for the community. I'll stop here for the moment, and then we can introduce the next intervention from Papua New Guinea. Andy, will you introduce, or shall I do it?
Please go ahead.
So last year I had the chance to visit Papua New Guinea for a monitoring mission. And during one field visit to a village called Hula, which is about an hour or two drive from the capital city, this can be considered as a hyper-endemic village. It has a population of around 4,000 or 5,000 people only. And it has, every year it reported around 20 or 30 leprosy cases, new leprosy cases in that village. So there, everybody knows leprosy because every family has some cases, or sooner or later, or they had in the past or so. So when we spoke to the community members and we said, okay, we have now a new tool, rifampicin, which could be given as a prophylactic tool. It's not perfect, but it has limitations also. It will not take away all new cases, but if we give it at community level, there is a chance that we can reduce the level of new cases with more than 50%. So if you have every year 30 new cases, if we treat a whole village, then probably we can reduce it to 50 new cases per year. So when they heard that, these people in the community were extremely happy and they were very much supportive. And we spoke also to the community leaders, including the pastor of the village, and so to convince them. They were immediately convinced, and they would be very happy to introduce SDR in their community. So that's why, as preparation for the global consultation from last month, I asked our country office in Papua New Guinea if they could go back to that village and take a video recording to interview the people of the village themselves, so that they can express what they want, why they want to have this intervention. So I propose that we can listen now, or can see now, this video. It's not a perfect video. Take all the inconsistencies or inconveniences of amateuristic work with it, but I think it's worthwhile to listen to something which comes from the community members themselves. Let's listen to this, or let's see this video now.
I take concern of my community. This disease or infection leprosy must be prevented. After I was affected by, on the day that I was affected by leprosy, I felt lonely.
This particular disease has been in our community for so long.
Loss of strength. I had a foot drop. I couldn't, I was beginning.
Access to health services, we have very poor system of supplying medicines.
I cannot feel this too. At first they were kept like this, but I was trained how to bring them straight. After 6 months of taking the drugs, then I came back to sense again.
The people who are affected, they find it difficult to go down to Mosul because they have to pay their way down to the health hospital. The port from here to Mosul is 15 kina, both ways is 30 kina. And if you wait on lunch and all those, it's very, very high. 30 kina is too much for an average person in the 30 kina is too much for an average person in the village. If you want to get the medicine, there is not a delay. Long lines of line, they also charge for getting treatment. Communication is a problem too. That's why this sickness never leaves the village. Because I believe this one dose treatment is a good idea to come to the village so that everybody will have a chance to get this treatment. They would be very happy to, if it was right here now, all communities would be present.
I'm beginning to bring this treatment, one dose treatment, as soon as possible.
Once this single dose treatment is introduced, I believe the community will have a very good future.
So I believe this single dose treatment is going to minimize leprosy. And I believe maybe it will finish off leprosy infection here in Carlos.
Thank you. And apologies for all the background noises and so. A lot of rumor was there in the background, but that's the real life. We are not in a 5-star hotel. We could hear the children and the chickens, and so that is the village life. That is what is happening at the village level in a fairly remote village in Papua New Guinea. I'll now continue my presentation with the second part on the WHO technical guidance on contact tracing and chemoprophylaxis, which we have recently published. And this answers the question, not what should be done, because that is in the guidelines, but how contact tracing and post-exposure prophylaxis can be done. So if a country has taken the decision to go ahead with contact tracing and or post-exposure prophylaxis. This guidance document will tell you what are the different steps in order to put it into practice. Next slide. This is the table of contents in this document. So it gives an overview of contact tracing, screening, and chemoprophylaxis, the roles and responsibilities of different entities. There is a chapter on counseling, which I will further elaborate as part of this presentation. And then we have the different steps, logical steps, identification, recording of index cases, listing of the contacts, tracing of the contacts, which means doing the visits to find out where they are at their home, screening of the contacts, which means the physical examination of the contacts to rule out leprosy, administration of post-exposure prophylaxis, then also word on supply chain management, so to acquire and to distribute rifampicin, recording and reporting, implementing contact tracing and PEP, including the planning, the training, etc. at program level, monitoring and supervision, and then a word on information, education, and communication. And then we have 3 annexes. One is the model contact list, and then 2 models for obtaining consent. Next, please. So what is counseling? And this is actually an old definition quoted from Pepinski and Pepinski in 1954. Counseling is that interaction between 2 individuals to find a solution to the problems which have an emotional angle of one individual. Such a solution usually includes the behavioral change in the individual whose problems are being discussed. You will have to read it 2 or 3 times before really fully grasping what is mentioned here. But it actually means that if we counsel a person, then it will be more easy, straightforward to convince that person what action needs to be done to take part in it, to give consent to it. And that's the whole idea, is to not to treat a patient as or a contact person as an object, but to really let them decide about it's their body, it's their health, it's their family, it's their disease also. So they should take an informed decision on the next steps, and therefore counseling is very important. Next slide. So who should be counseled? We're talking here about counseling of patients. Well, it's the index case, every new patient, the source case, every new patient that has been detected should be counseled, should be properly informed about the status. When should counseling be done? It could be done at any time, but most important is to do it as soon as a diagnosis is made. And even we call it the golden hour. At the very beginning, if you tell somebody they have leprosy, they are maybe overwhelmed, they may have many questions and so that need to be answered, but it should not be limited to that, because we know that a patient should know, maybe is not well aware of what is leprosy and all what comes along with it. So we need to provide a lot of information. One session may not be sufficient, maybe multiple sessions, longer time, alone, maybe with partner, with family. We have to repeat it after 3 months because information may be too difficult, too much to absorb at one time. So at every occasion, we should take enough time to explain to the patient what is his situation, what is his status, etc. So there is no harm in repeating it periodically at every interaction with the health service or any other opportunity. Who can provide counseling? Ideally, a professional counselor, but that may not be available in most settings. So we may have to do with other persons, and other people can perfectly give counseling. Could be health workers, doctors or nurses or other people, but it can also be trained peer counselors. And with that we mean a person who has experienced leprosy. So former patients, cured patients, are actually well placed to provide counseling. They have gone through the whole process of diagnosis, the classification, disease, treatment, follow-up, etc. And they know very well all the steps, and they are well placed to explain to other people what it means to go through it. And because they have gone through it, they are very credible also for other persons. So I think investing in training for peer counselors is a very worthwhile investment, and they can contribute very much to counseling and motivating other patients. What should a patient be counseled for? Well, on the basic facts of leprosy, on what is the risk for infecting others, on the treatment duration, on the side effects maybe, but also on prevention. And that is actually the subject of today's session on contact tracing on single dose rifampicin, and also maybe on the management of disability, etc., etc. Next slide. Then we have also counseling of contacts. Contacts are the healthy people living in close contact or in more distant contact with the index case. So who should be counseled? It's the contacts. It can be the family in the first place, eventually the neighbors, or the social contacts. Social contacts could mean, for instance, colleagues at work, or people attending the same sports club, or anybody who you come in contact with on a frequent basis, but is not directly a blood relative or is not necessarily living in your neighborhood, but you have significant hours of contact with that person. But in the case of blanket approach, we should counsel the community without identifying, without referring to the index case. Usually the community will know, like in that village in Hula in Papua New Guinea, the community knows very well there is leprosy in their village. They don't need to be counseled very much on the fact that there is leprosy. They know very well, and they know probably quite a lot about the disease also. So, but it's good to properly inform them about the status of leprosy and what can be done to reduce it in future. So who can provide counseling? It's actually the same as in the previous slide. Ideally a professional counselor, but that person may not be available necessarily, and that should not be a big issue also. Counseling can be done by any other interested, motivated person, including health staff, but also peer counselors, which means patients, former patients who have been cured, who have gone through the whole process and who are well placed to motivate other people and community members. And what to counsel, particularly with regard to contacts, is on the transmission of leprosy, the possible risk of developing disease, prevention of leprosy with SDR, how to administer SDR, something about the safety of rifampicin, maybe about the side effects that the urine is coloring red for one day, etc., but that's very, very limited. The limitations of PEP, it's not a perfect tool. The reduction is not 100%. The reduction is between 50 and 60%, but we are very happy with such a major reduction in leprosy, and something also about early signs of leprosy. So with regard to good counseling practices, I'd like to refer to the e-modules on counseling in leprosy, which you can find on the web link below. So this mentions that being well informed and giving correct information about the disease is important, and we should give correct information. Don't say things which are not correct or which are ideal. Giving correct information about leprosy, not only to the patient, but also to the family and also to the wider community, particularly when we apply blanket approach. Being friendly, reassuring, encouraging. We have to show empathy to motivate patients, but also to respect them. If they have any questions, try to answer these questions, resolve the doubts, allow them to ask questions because they may have many questions. So the counseling session should not be a one-way. We should ask feedback from patients, have they understood. If they have any questions, allow them to ask these questions and try to give an answer to them. Important also maintain confidentiality. That is not limited to leprosy. That's for every counseling session, be it also for HIV or for cancer or whatever it is. I think it's a medical practice that counseling should be done in a confidential way, privately, respecting the privacy of people, having the proper setting also, either in a hospital or in another decent counseling room. Avoid unnecessary investigations. We should stick to the point and not probe into things which have nothing to do with the issue we are counseling the patient on. And advise patients to start treatment as early as possible and complete the treatment, the full treatment for cure. So that is what is covered in these e-modules on counseling. Next slide. Then let's now move to consent taking. As I mentioned, why do we need consent? Because we deal with people, with patients who need to be respected and who are autonomous. So they have to give their agreement before we move further. So we need the consent of the index case, asking permission to disclose his or her disease status to their contacts. Because leprosy, we know, is a stigmatized disease. we must be very careful. You would not like that they tell behind your back that you have leprosy to everybody. So therefore, we need to seek their consent. It could also be partial consent, where the patient agrees to disclose his or her status to their family members only, but not to the neighbors or not to social contacts. Okay, then we move on with contact screening and maybe offering SDR to family members only and not to the wider circle of contacts. And if there is no consent given by the index case, then it stops there. And we should not move ahead with contact tracing. We should respect the fact that an index case wants to have his status not to be disclosed to her family members. We can, of course, try after 1 month, after 2 months, to provide a fresh counseling session and see whether the patient may have changed his or her idea by that time, and then can still move ahead at that point of time. And consent of the contact case is also required to be screened, but also to be treated with SDR. We cannot just do a body check of somebody like that. These are healthy people in the first. Most of them are healthy persons in the first place, and only a very few cases will be patient among them, and the others will have, the healthy people will be asked to take single dose rifampicin. So this is the right to take it, but also the right not to take it, and that right should be respected, and therefore we need their consent, and they will give their consent. There's more likely to obtain consent if they are properly counseled. Again, here, if a contact case does not agree, then SDR should not be given. So we should allow that they have the right to refuse to take SDR. No consent of the index case is required in case of blanket approach. We can just say that people will know there is leprosy in the community, and therefore we would like to check everybody and offer SDR to everybody. We still need to have consent of the person before taking SDR. We cannot force them to swallow capsule of rifampicin. So what are the limitations of this tool? As I mentioned earlier, it's a very useful tool. It's a very helpful tool. It has helped in popularizing contact tracing, in reinvigorating national programs, but it is not a perfect tool. So the efficacy is about 57%. So and it is less effective, or it tends to be less effective if the index case is highly smear positive. It's less effective in the closest contacts. It's more effective in the social contacts. And probably the reason is that the close contacts may have also more likely to be infected and for a longer time, and therefore have more bacilli in their body. And also leprosy may not have been completely ruled out. And of course, if a person has already leprosy but was missed because the body check was not properly done and so, then SDR, of course, is not going to cure leprosy, but it may additional symptoms may come down the line, and then we think that SDR has failed. It doesn't mean SDR has failed. It's just that leprosy was already present but was not recognized at the time of giving SDR. But otherwise, it's a very effective complementary tool to early case detection, which remains very important, and prompt treatment. That is a cornerstone of leprosy control. That remains so, and contact tracing can promote early case detection, and also vaccination at birth with BCG, particularly in leprosy endemic areas. So I leave it to here, and I invite next slide, any questions, or we can keep the questions for the end of the session. Over to you, Andy.
Thank you, Erwin. I'd now like to invite Alice Cruz, UN Special Rapporteur Alice Cruz, pardon me, to join us for a conversation about key considerations for collaboration between organizations of persons affected and individuals and SDR-PEP implementers. Over to you, Alice.
Thanks, Andy. Well, good morning, good evening, good night to everybody. Thanks for the opportunity to bring a human rights perspective to the discussion. First, if I may, let me start with clarifying what are we talking about when we talk about discrimination. We need really to move beyond the functionalist approach to stigmatization that regards stigma as a natural consequence of a disease that makes people fear the patient. Discrimination is really much more than that. Discrimination refers to any unfair or prejudicial treatment of people or groups on the basis of perceived characteristics, and discrimination usually leads to loss of opportunities, material deprivation, structural disadvantage, stigmatization, and poor access to states, goods, and services. So this means we need to look at discrimination from the point of view of unequal power relations. This means that people that are discriminated against many times do not have the means to fight back discrimination. And a word to national leprosy programs who are, of course, very interested in the discussion here, is that discrimination, in fact, is a social determinant of leprosy. It can be, easily identified in the fact that poor communities with household crowding are more vulnerable to leprosy. It can also be identified in the fact that physical and economic lack of access to healthcare services also has an impact in leprosy, but also, it also interferes in the outcomes of health policies and public health strategies. And many times we hear persons affected by leprosy saying that they do not feel cured, even though they are cured, because in the meantime they have developed physical impairments. And that many times has to do not only with biological issues, but also with social, economic, and cultural issues. In the case of leprosy, discrimination, and I have been able to map ongoing discrimination, structural violence, human rights violations against persons affected by leprosy and their families. And I have made a very descriptive mapping of this in my 2019 report. The fact is we still have discriminatory laws, persistent of social inequities that have not yet been addressed, pervasive harmful stereotypes. There is still much the sense that leprosy is a result of sins committed in current or past lives. It's a punishment from God, the doing of evil spirits, and all these harmful stereotypes have a huge impact in the way people are treated in their communities. But we also need to realize that many persons affected by leprosy and their families continue to experience, many times in a silenced manner, stigmatization at the community level, but also interpersonal violence within the family. Especially women continue to experience psychological, physical, and sexual violence. Children suffer from discrimination at school, which reduces their chances, their opportunities for having access to, improvement of their life conditions, etc., etc. So we need to understand what discrimination is about, but also that it also depends very much on already existing categories that exclude people. Let me explain this. Women, from a poor background are more vulnerable to discrimination than a white, middle class, and well-educated men. So we need to look at intersections between leprosy-related stigmatization and other categories that have been subjected to oppression and subordination. And since we are talking about PEP, I would like to call your attention to the fact that there are still many reports coming from persons affected regarding institutionalized discrimination at the level of health services. And if I may, I'll try to be quick. This is also related to the fact that there is still an understanding that scientific or technical knowledge is superior to the knowledge that is produced by experience. So there is this power imbalance that none of us can deny when it comes to the relationship between medical providers and users. And not much has been done to invest on developing structural competence of the healthcare workforce, meaning that many of the healthcare workers are not aware of the cultural dimensions, socioeconomic dimensions that make people's lives and that have a huge impact in terms of stigmatization related to leprosy. So we have this imbalance, which is related to, greatest power being given to medicine than to the experience of users. And I recommend, if we try to invest more in translation processes between these two knowledges, looking at them as, equally valid knowledges. This is a challenge, but I think this is something that really needs to be done. And the people's organizations can help a lot with regard to this. We have, of course, the individual experience of leprosy, which is highly important and should be taken in consideration in this medical encounter. But we also have the knowledge that organizations develop. And people's organizations do not only know well their community, so they are able to map all these social, economic, culture, political dimensions that mediate the outcome of public health policies, but they also have a standpoint. And what it is a standpoint is, something that comes from a very situated knowledge and related with specific demands that people develop in order to seek for an improvement of their lives. So by the one hand, the people's organizations develop this situated knowledge. They are, in my view, experts on health and equality data. And I would recommend you to try to do a bit of research on what has become known as popular epidemiologies. Grassroots organizations are very capable of mapping the intersections between material, social, economic variables that impact the well-being of communities. And by the other hand, we really need to take this knowledge into policy making. So, moving forward, I would say that if the people's organizations are translators by excellence, because they are many times able to deliver to the communities basic health information and support the process through which people engage with health services, I would say that health providers also need to learn more from the people's organizations, and that translation needs to be mutual. Moving forward to what do the people's organizations in their work? Well, the people's organizations really act in all levels. They act at the community level, they provide peer counseling and support. They also promote health education, they do outreach activities, and they also can do counseling at health services. But they also act at the national level. They engage in advocacy, lobbying, monitoring, demands for accountability. And they also provide, and this is a very important work they do, general support to vulnerable communities regarding what are inaccessible states, procedures, and bureaucracy, for instance, in regarding to access to social protection measures. Their work has an impact both at systemic change in terms of rights enforcement and guarantees, but also in terms of improving the self-esteem and mental health of people affected by leprosy. I have seen this, and this is really powerful. People as Dr. Cooreman was saying, and also the gentleman from Papua New Guinea can feel very lonely when they are diagnosed with leprosy. And these organizations really support people to come to terms with the diagnosis, but also to develop a positive identity related to leprosy. The COVID-19 situation in crisis has shown us how the people's organizations are the first to act. And they have been very active. In terms of mapping problems, they are the ones who were able to map the problems generated by this crisis. In terms of problem solving in a quick manner, as I learned in Morin, there is the time of the state, which is slow, and there is the time of grassroots and national organizations of people affected, which needs to be quickly because they are responding to urgent demands. They have also engaged in emergency aid, health education and counseling, many times doing what the state was not doing. So coming to how, and this is what I was asked to talk about, how can the people's organizations who do this amazing and many times not sufficiently acknowledged work can engage with PEP? Well, obviously they are translators. So they can support the process through which information reaches people in health services and at the community levels. They can, of course, also provide a great deal of support in terms of preventing further stigmatization of individuals and families due to this intervention. But I would say that this is the obvious role they can play. I think that we need to look into how national leprosy programs and other stakeholders engage with people's organizations in order to ensure that there is no double standard in the implementation of this strategy, meaning the fact that when it is applied to developing countries, the existing conditions of deprivation and social inequalities cannot lessen the importance of ensuring the voluntary nature of informed consent. So I would say that the conditions sine qua non for avoiding any double standard are ensuring the right to access to information, informed consent, and true and meaningful participation in decision-making and designing of strategies from the people's organizations. So I would say that if this is well done, this is an opportunity for stigma reduction because it will enhance the knowledge the communities have on health-related issues and on leprosy too. So what do we need to ensure? And Dr. Cooreman already talked very well about informed consent, but let me give you the human rights perspective on informed consent and the right to access to information. As my former colleague, Special Rapporteur on Health, Paul Hunt, wrote in one of his very good reports, he says that the requirement of human rights accountability extends to both the public and private sectors. Additionally, it is not confined to national bodies. It also extends to international actors working on health-related issues. I think this is an important call for to us all. The right to access to information is included in some of the international human rights instruments that we have. Especially the International Covenant on Civil and Political Rights. It is also integrated in many constitutions and it has been applied by a great deal of relevant bodies such as the European Court of Human Rights, to give an example. Also important is to look at the linkage between the right to health and the right to access to information. The entitlements include services that are available, accessible, acceptable, and of good quality. The freedoms include the right to control one's health and body and freedom from non-consensual interference. Informed consent has also been codified by several instruments, and I would like to highlight the 1994 declaration from the WHO on patients' rights that requires informed consent as a prerequisite for any medical intervention, guaranteeing also the right to refuse or halt intervention. It is also codified on the Article 26 of the Convention on the Rights of People with Disabilities, which is very important for the leprosy community. So informed consent must respect personal autonomy. And as Dr. Cooreman very well explained, it needs to be made very clear to people that SDR-PEP is not a vaccine, because this can be easily misunderstood. It needs to ensure completeness of information. It requires disclosure, not only of the associated benefits, but also to the risks and alternatives to that specific medical procedure. So importantly to mention the risks, and I will not dwell on this, but you all know the risks of PEP and limitations, as Dr. Cooreman was mentioning, and this should be made absolutely clear to people in order for them to make an autonomous decision. But communication should also take into consideration the varying levels of comprehension and not be too technical, complex, or in a language that is not accessible to people. But this should not mean incomplete information. And in this specific point, of course, people's organizations can have a very important role in ensuring the translation process. But we also need to be concerned about, as I said before, discrimination on the grounds of leprosy is not, we cannot separate that from specific conditions in which people live. So we need to find manners to ensure that informed consent is accessible and reachable to women who many times are discriminated against in health services, dependent on third-party authorization to use health services. And I would say, you know, as Dr. Cooreman was mentioning, contact examination is crucial in order to make sure that that specific person does not have leprosy before giving that person PEP. And contact examination can be a challenge if not done by other women to women in many contexts. How about children? You know, the Convention on the Rights of the Child demands respect for the child's evolving capacities and due weight to be given to the child's views according to age and maturity. So risks and benefits of medical interventions must be adequately conveyed to the child. How about indigenous communities? For them, collective consent is needed, and this is very much related to the blanket approach that Dr. Cooreman mentioned. We need to develop also ways to ensure collective consent. So basically, we need to respect people's legal capacity. Legal capacity means that competency to consent is a status that is generally determined by the ability to comprehend, retain, believe, and weight information provided in arriving at a decision. So just to conclude, I would say that, and I saw Dr. Wim's question on if the need to ensure that health workers are trained in counseling. I would say that we also need to ensure that, yes, but also that what I said before, a structural competence of the healthcare workforce, and the fact that low literacy populations require additional efforts to facilitate comprehension of technical concepts, which means that appropriate support mechanisms to help overcome subsequent challenges to achieving informed consent should be put in place, including community involvement and comprehensive counseling, which of course can also be very successfully done by the people's organizations as well. Well, to conclude, as Special Rapporteur, I would like just to call attention to two final points. Any strategy of this kind cannot get into the trap of what João Biel, an anthropology, called the pharmaceuticalization of public health. We cannot rely on magic bullets. So, in order for PEP to be to reach the results it is expected to, we need to continue to put a great deal of effort in other strategies, as Dr. Cooreman mentioned, but also in universal access to healthcare, high quality medical care, and socio-economic empowerment. We also need to ensure the full and informed participation of people's organizations in bottom-up designing of public health interventions and public health policy making. Thank you very much.
Thank you, Alice. That was a wonderful segue into our next presenters who will be joining us from Nepal. Mr. Timulsina from IDEA Nepal, a people's organization, and Mr. Banstola from NLR Nepal will join us next to speak about their experiences collaborating in SDR-PEP implementation in Nepal. So I now invite Mr. Banstola to start us off.
Okay, thank you, Andy. Good afternoon and good morning, everybody. I'm Nand Lal Banstola from Nepal, and I'm working with NLR since the last more than 20 years. Today, in this short time, I'm talking about SDR-PEP and involvement of persons affected from our experiences of SDR-PEP interventions in Nepal. Next. So here in this slide, we can see that it is obvious Nepal is one of the leprosy endemic countries in the world. And in the last 20 years, more than 93,000 new leprosy cases are detected in Nepal. Target of leprosy elimination was achieved in 2009, but it was declared in 2010 at the national level. Can you press the key once? But even after the elimination, new cases and new case detection rate remains almost the same, indicating that transmission is not interrupted, and it clearly suggested need of additional strategies to control the leprosy in Nepal. Reasons for continued transmission may be different, could be delay in the diagnosis. In one of the study, it was proved that in Nepal, the delay in diagnosis is almost 4 years. And maybe it may be possible transmission before clinical symptoms. Next. So that Nepal government decided to implement LPEP as additional strategy in Nepal. LPEP was started as a piloting in 3 leprosy endemic districts from 2015 to 2018. During LPEP, we covered all the prospective cases, that is ongoing cases, but retrospective cases from the last 2012 and onward. But after LPEP piloting, we changed that strategy, and in recent SDR-PEP interventions, we are covering the index case of the last 20 years. Next, please. And about the contacts, we adopted the mixed contact approach in Nepal. For the contacts, we assume these are the risk population groups of getting leprosy. And in the mixed contact approach, we covered household contacts, neighbor contacts, and social contacts. As previous speakers mentioned, in all these cases, for the index cases as well as for the contacts, the consent was necessary. Everybody should take the consent, get the consent. Next, please. Yeah, this is the milestone. Since the preliminary results were quite encouraging, especially for the community mobilization, and health workers were very enthusiastic, the expansion was started to other districts. It was started from 2017, and today, by 2020, next please, SDR-PEP intervention has been reached to the 23 districts of Province 1 and Province 7 of the country. As this is the continued process, in the very low endemic districts, we covered almost all the reported cases that I already mentioned since the last 20 years. But in the hyper-endemic districts, it is the continued process. The new case reporting is continue. Next, please. Now I'm talking about some of the outputs. For the index cases, we already covered 3,647 index cases. Even in 2020, a smaller number we could cover. Next. And more than 68,000 contacts of those index cases are provided with single dose rifampicin. Next, please. And from direct interventions of this SDR-PEP, 189 new leprosy cases and also 25 new tuberculosis cases were diagnosed. So this SDR-PEP is not effective only for the community mobilization, but also effective for the detection of the new leprosy as well as the tuberculosis cases. Next, please. Yeah, now I will talk something about the involvement of the persons affected. Now, from our experience, we have said what steps could be for the SDR-PEP and who are stakeholders who can contribute in which of the steps. It is already said. First of all, we train all the stakeholders, including the persons affected, and then they will play their role depending upon their capacity. Next, please. Yeah, about the persons affected, their involvement is ensured from the very beginning. That is from the designing of the program or planning to the level of the implementation. For example, in the different level, starting from the national to the municipalities, there are the different committees, task force committees, where persons affected are themselves the members in this decision-making process. And for the review meetings and other types of the meetings, they play the vital role. As I already mentioned, they also participate in training and orientation program. And important thing is, due to this reason, they mobilize their networks for the community awareness and peers counseling. Next, please. So this is simply the scene where Mr. Amar, the IDEA chairperson of Nepal, he moderated the LPEP dissemination session in 2018 and being honored by the Director General of Health Services in Nepal. Next, please. Yeah, at the implementation level, that I mean at the municipality level, where SDR-PEP implementation steps are followed, there are two types of the activities. If the persons affected organizations are active enough, that means they can mobilize the other parts of the community. They can take the whole ownership of the program, but they will take the support from the health workers and municipality team. But in some municipalities, they are not that much sufficient to take the overall ownership. In that case, they will contribute, they will participate and contribute for the certain steps of SDR-PEP implementation that is displayed here in this slide. Next, please. So, involvement of the persons affected, it is equally benefit themselves as well as for the SDR-PEP program. Here I have mentioned some of the examples. So, as I already mentioned, in those places where persons affected or their organizations have taken the full role, the contact acceptance is higher, refusals are very low, and temporary absentees, for example, less than 2-year children, after the certain period of the time, he will be eligible to take the rifampicin, or pregnant women, then those temporary absentees are followed up. That is long-term follow-up. Follow-up is possible. Persons affected has taken that role. And for the program, the community perception change about the persons affected. They are recognized as the development contributors rather than the recipients. That reduces or vanishes the remaining stigma and discrimination against leprosy, I mean. And another important thing is full potential or access at the policy level will be provided to the persons affected. Next, please. That's why, from our experience, what I like to say, without the interactive involvement and contributions of the persons affected by leprosy, SDR-PEP interventions are just the formalities rather than producing the expected results. Next, please. So, due to the introduction of SDR-PEP, in 2020, we could cover only very less numbers of index cases and contacts. It is due to COVID. That was the big challenge, which is common in every part of the world. Next, please. And finally, we are following the SDR-PEP interventions since the last 5-6 years. Government of Nepal has clearly mentioned it in the policy interventions, policy documents. So, from these all development, I would like to mention we are a step closer to beating leprosy from Nepal. Thank you. Thank you, Andy.
Banstola. Now I will invite Mr. Timulsina to share a little bit more about his perspective on working with SDR-PEP implementation in Nepal.
Thank you, Andy. Good morning, good afternoon, good evening, and good night to everyone, wherever you are. First of all, I would like to express my deepest thanks to WHO Global Leprosy Programme and Global Partnership for Zero Leprosy for this wonderful opportunity to present an SDR-PEP webinar from the perspective of the one affected by leprosy. Dear distinguished presenters and valued audience, accept my greetings from Nepal. I am Amar, Timulsina, President of IDEA Nepal. My colleague from Nepal, Mr. Banstola, presented, he had a wonderful presentation and almost everything he covered. So I would like to add some more from the perspective of a person affected by leprosy. In my view, we have to focus on the direct involvement of the persons with first-hand experiences for the more effectiveness of SDR-PEP. I think it will add higher impacts for acceptance in the community. It is vital that community must agree to accept the dose, and making them agree requires making them aware of the facts related to leprosy, its consequences, and most importantly, prevention perspective. And if a person affected themselves devote in such work, and then I'm sure the outcome will be additionally significant. Importantly, what we can do is we can organize a meeting in the local level in which our participants will be the local stakeholders, educational institutions, ward offices, self-help groups, cooperatives, health centers, and other organizations, including organizations of the disabled, which my colleague, Mr. Banstola, also mentioned in his presentation. Through the meeting, we can make the participants aware of the effectiveness of the project. They will play a vital role in pursuing the dose to the ones who have come under the contact tracing. Next slide, please. At the same time, when the persons affected themselves lead as the frontliners, this will greatly encourage the other people in the community who are hiding disease to come out for the diagnosis and treatment. This will greatly help in reducing social stigma and discrimination related to leprosy. Thus, the meaningful and impactful participation of persons affected have hugely impacted the SDR-PEP. I would like to propose the direct involvement of the people affected by leprosy in SDR-PEP for the added effectiveness. Will have following benefits if done so. 1. This will engage the persons affected by leprosy as leaders, which will enhance their capacity. The community champions will be the glaring examples for the mitigation of the discrimination. Number 2, this will encourage other people if they are hiding their disease, which will prevent disability caused by leprosy in the community. Number 3, more people will be drawn under contact tracing. Number 4, the SDR-PEP will have significant results. 5, the practice of involvement of people affected by leprosy in the related projects will be continued in the days ahead. Keeping aside the medical aspect of SDR-PEP, I sincerely plead to all the concerned to have another eye on the educational and economic aspect of the experienced person. It is the economic level and the educational status that hinders them to combat against the cultural interpretation of the disease. If they are economically independent and educationally sound, they would be less scared to openly accept their leprosy cases. Even today, our own brothers and sisters affected by leprosy, who are also members of IDEA Nepal, hesitate to expose in fear of stigma and discrimination only because they do not have good economic status and are not well educated. Now, I would like to share you my own experience as a lived example. When I was diagnosed with leprosy, and I was undertaken with medicine, I was rejected and ostracized from my own community. Now I'm educated and running my own business. So there is no discrimination, no stigma, no rejection, and no ostracism in my life. If so, why don't we more focus on the educational and economic aspect of the experienced person? Thank you so much. Thank you so much for your kind attention. And Auntie, over to you.
Thank you very much, Amar. Our final presentation this morning will come from Mr. Tesfaye, who I would now invite to join us, and I'll share his slides. And one more note. We're rapidly approaching the end of our time for this webinar, so I would encourage anyone that still has persisting questions that they were waiting to ask at the end to go ahead and put them in the Q&A, and our panelists can type responses to those during this final presentation. Thank you.
Okay. Thank you. First of all, I would like to say, well, I would like to convey my warmest greeting from Ethiopia, from Addis Ababa, from Ethiopia. And at the same time, I will really, I would like to thank you, the WHO team, in coordinating these conversations, and the participation of ENAPAL in behalf of persons affected by leprosy in Ethiopia and all the other world. So saying this, I'm going to present my presentations. Please, can you? Yeah, thank you. This is the first slide is talking about what's Ethiopia. This is general information for those who are not really familiarized with Ethiopia, as Ethiopia is found in Africa, and we have about 120 million peoples. Also, we have a variety of culture, and still we are in the line of the growing. Saying this, next, please. Next. Yeah. Then, please, can you go to the next slide? Yeah. No. Yes. Thank you. No. Yeah. Back. Yeah. This is, Ethiopia. We are leprosy organized associations. ENAPAL is a big association in Ethiopia. It's organized. We are working on 7 regions of the country. We cover almost 80% of the country, and still we have strong associations that can advocate for themselves and to fight stigma and discriminations, and even to stop the transmission of the leprosy. And this is where we are working. Okay, next, yeah. So what is the situation of leprosy and disability in Ethiopia? This is just to give you some picture of how leprosy is in Ethiopia. Still, Ethiopia has a great number of leprosy. We have about 4,000 people are reported per year. Out of this, the number of the grade 2 disability is also high. And also among the new cases, there are high number of children, almost are about 12% or something are coming with the new child leprosy cases. So this is really a very shocking, and also what that needs the integration, the integrated effort of the concerned partners. Okay, next. So strategically, ENAPAL is focusing on the community awareness, because still we have to, if we are not really advocate for ourselves, nobody is, no one can support, no one can really speak about the people affected by leprosy. So in order to this, ENAPAL organized and creating huge or large variety of community awareness that's on sign and symptom of leprosy to end up or to reduce the stigma, I mean the new cases, And also we are working on the awareness that's to stop or to reduce the discrimination, stigma and discrimination, because leprosy is not only the medical disease, it's also a social problem. It's a social problem, especially in Ethiopia. Many people are still stigmatized. They are living in the settlements of the leprosy. So the association is really working on these things with higher government officials and other partners to minimize, to reduce the stigma, and also to prevent further disability, because people, because of their fear, they are still they are not they didn't go to the hospitals. So we are working with these people on these people to come and treat themselves accordingly. So even at the same time, so we can advocate on the right use of the facilities with the government, or the right provision of the facilities for these peoples with the government. Okay, next. And so far, as everybody knows, that there are milestones on leprosy interventions. Actually, everybody knows that the middle age, or that is, I can say that it is the darkest age, because during that time, as leprosy is considered as a curse, and it's hereditary, and that cannot be treated, and it is transmitted. So people are, because of these, people are very stigmatized and discriminated, violated their rights. So that time was really a very dark time for people affected by leprosy and their families. Next to this period, the modern time, that's when dapsons and the multi-drug therapies being used. This is the beginning age. Still, gradually, leprosy, people are knowing about the leprosy, but some people are getting treatment, but still the issue, the problem is remaining. Next. Yeah, the current stage, that we can say that the progressing approach, that is preventing leprosy using a single dose of rifampicillin. This, since leprosy is remaining endemic in many countries, that substantially needs new scientific approach to reduce stigma, to reduce the burden of the new cases as a result, and the result of stigma. So this stage is a very important stage. This progress is a very important, because still the attitude of the people still, of course, we are on the better age, but still there are a number of people do not really get on time treatment, and they don't want to show themselves to the medical, and even they hide themselves at home levels. So this for these problems, if such kind of preventive mechanism is employed, so we can save many people. Like passive case detections and treatment with MDT alone could not stop the transmission successfully. Still, there are a large number of new cases being identified across the world. For instance, in Ethiopia, more than 4,000 people newly affected by leprosy, with 30% were children under 50, and 40% were grade 2 disability. So this situation, next. This situation needs new mechanisms, new approach. So the new approach is the preventive using of preventive chemoprophylaxis for the contact, for the contact of the leprosy. Therefore, we need to exercise the new initiative, which is called preventive chemoprophylaxis that may be used as a leprosy preventive treatment for the contact of the leprosy patients, adults, children, and others after excluding the leprosy and tuberculosis and absence of other contradiction. So this this approach is very important, and it introduces a new initiative in the leprosy. It is evidence-based. It is a national programs that consider the initiatives. So please, next. So as an organization of persons affected by leprosy, we are really appreciate the idea of the contact tracing and preventive chemoprophylaxis as a means to reduce transmission, which is recommended by the WHO. So, but as my colleagues presenting earlier, we should, when we are implementing this strategy, we should consider that we should, or ENAPAL, or as ENAPAL as organization of persons affected by leprosy, we suggest that the intervention should be implemented only by the programs that can be ensure adequate management of the contact and consent of the index, because it is sometimes still, as Dr. Alice mentioned, that still the stigma and the discrimination is still, there are structural, and there are at family levels, at government levels, at the community levels, still the stigma is there. So we have to manage that appropriately with the consent of the individuals. And then the other is, it has to be systematical, integrated with other like skin and TB campaigns. So, for example, if we are arranging this kind of screening situation together, it's clearly without any stigma, we can identify that, and we can treat that persons, that individuals separately with ethical ways. So to divert the attention of the other people, if it is accompanied with other campaign, we suggest that. Also, it has to be ethical and professional, because as because the counselors, it needs a counselor, as it is mentioned early, or professionals, because still the situation of the leprosy, the situation of the leprosy is very critical, because more of the issue of the leprosy is related to the stigma and discrimination. So it needs a professional counselors and professional who are really committed and ethical. So the other is, it follows the community sensitization, because we have to sensitize the community, the importance of the contact tracing. And so such kind of early awareness of the community is very important, because one, it makes the mind readiness of the, it creates the mind readiness of the people. So, so finally, following the community sensitization and the family, also we have to work on the family-based approach, because ENAPAL has a good experience that working with a family level, at the family level, is very important, because the stigma starting from to change the mind of the family. If something is happened, they have to ready to accept. And if someone is really diagnosed with a leprosy, they have to treat him. So we have to work on that. Next. This is ENAPAL experience, that how people affected by leprosy are creating small groups to care about themselves. So we have to use such kind of mechanisms to mobilize the issue, the community, and to create to facilitate the contact tracing, because ENAPAL has a good experience to such kind of self-care groups and family-based approach groups. Next. Okay, this this is how really currently, ENAPAL is not only working on the leprosy, but still we are working on the podoconosis and lymphatic filariae leprosy affected peoples together, because all these peoples, because of the disease, they are stigmatized and discriminated. And in Ethiopia, people, those who have podoconosis and lymphatic filariae are living or inhabited with very close with leprosy people or affected people. So we have to just we have to deploy, we have to act or together to reduce the burden or to mitigate the burden. We have to just using all this kind of things like self-care treatment and family-based treatment. Kind of self-care management is good. This is a kind of community awareness. If one's community is aware about the disease, and if community is aware how to prevent the transmissions, it is a means. So as an organization of persons affected by leprosy, ENAPAL is strongly work on the community mobilization. So if as WHO is really recognizing the importance of the disabled organizations, that is a good means to address the results or the problem, to address the problems properly. So ENAPAL generally we are appreciating the initiative, and we are hopefully we are collaborating and we are mobilizing the community to implementing the strategy. Thank you. Thank you.
Thank you very much, Mr. Tesfaye. We appreciate your presentation. And thank you one more time to all of the presenters for sharing their valuable perspectives today. We've reached the end of our time, so I'd just like to say one last thank you to the WHO Global Leprosy Program for their assistance in making this event happen, and to all of you that attended here today. I know that we didn't have as much time for questions as we anticipated at the end, so if you still have lingering questions, I would encourage you to send those to info@zeroleprosy.org, info@zeroleprosy.org, and we would be happy to connect you with a presenter if you still have a question for them. Thank you all very much.